We are excited to host this Healthcare Town Hall with the Alaska Policy Forum, and excited to be able to participate with Foundation for Government Accountability as our speakers, who are going to be presenting a significant amount of research as it pertains to healthcare, in particular tax credits to do with the exchanges, as well as Medicaid expansion and what that would look like for Alaska, its impact on particular groups as well as our senior citizens. And we look forward to a healthy discussion at the conclusion of the presentation of the research. We just would like to encourage people to be polite and respectful, as you would anticipate a response to be back to you. Obviously, as Americans for Prosperity, we would love to see the ACA repealed, but this particular discussion will be focused around solutions. It'll be focused around answering your questions of what is going on with healthcare, and we invite additional questions so that we can hold further discussions in the future. So with that, I'll immediately turn it over to Josh and Christy, who are both senior fellows with the Foundation for Government Accountability, and we can get the show on roll. Thank you.
Thank you so much for being here. I apologize that Josh and I were a little late, but as Josh was telling me in the car, at least we're a little bit more on time than healthcare.gov. So I want to thank you all for coming out. My name is Christy Herrera, and I'm Senior Fellow at the Foundation for Government Accountability. FGA, we are a health and welfare-focused think tank. We operate in all 50 states, and we help state officials with health insurance reform, Medicaid reform, and child welfare reform. As you know, Obamacare was a 2,700-page bill. It's really kind of hard to wrap your brain around everything. In fact, you all might have seen that H&R Block commercial with their employee, Anna Maria, and she said, "I've read the entire thing, and I can help you." Well, unfortunately, we're not all like Anna Maria. We don't all have that kind of time. So I think when you think about Obamacare, the easiest way to think about it is really like a three-legged stool. And on one leg of the stool, we have mandates. And these are mandates that require ordinary people like us and businesses to buy government-defined health insurance or else pay a fine. There are a lot of questions surrounding the mandate. Will enough young people buy health insurance coverage to make health insurance cheaper for all of us? Will President Obama give the same one-year delay to individuals that he did to businesses for this mandate? The second leg of the stool is the health insurance exchange. These health insurance exchanges are new entities designed to regulate and subsidize the purchase of health insurance, and Josh will talk a little bit more about that. What I want to talk to you today about is the Medicaid expansion. That's the middle leg of that stool. Medicaid is a government health care program that mostly serves low-income parents and children. It serves the disabled and some folks on Medicare. Today, about 130,000 Alaskans are on Medicaid today. And what the expansion would mean is an additional 30,000 to 40,000 more Alaskans on the Medicaid program next year. So how do we know who qualifies for Medicaid? What the federal government does is they define the word poverty by how much you make. That's called the federal poverty level. The box shows what the federal poverty level is for people here in Alaska. About $14,000 for a single person, about $29,000 for a family of 4. Even before the governor and the legislature think about Medicaid expansion, Medicaid today already covers kids, covers low-income parents, covers the disabled, and in some cases, these folks can make 2 times the federal poverty limit and still qualify for Medicaid. For example, a pregnant woman making $29,000 a year, she can get Medicaid. A young adult earning $18,000 a year, they can get Medicaid. I mentioned that Obamacare is like this three-legged stool. Why is it like a three-legged stool? It's because all of the parts are designed to kind of work together. Take, for example, Medicaid and health insurance exchanges. Along the bottom, kids, 19 and 20-year-olds, pregnant women. All of those are populations that Obamacare tries to cover. The light blue bar on the bottom shows you what you need to earn in order to get Medicaid. The dark blue bar on the top shows what you need to earn to get health insurance subsidies within the exchanges. Many states have what's called a gap population. In other words, there are a lot of people who make too much to qualify for Medicaid, but not enough to get these federal health insurance subsidies. But as you can see, Alaska really doesn't have a gap population. Everyone is going to be covered either through the Medicaid expansion or through Medicaid today or through the exchanges. Even before the expansion, Medicaid covers kids, pregnant women, and the working disabled even more than what Obamacare requires. For other groups like young adults and parents, Medicaid expansion means that Alaska will now be on the hook for health insurance costs for these folks through Medicaid when they could have gotten coverage on the exchange. So when we talk about what Medicaid expansion really means for Alaska, the group that we're talking about the most are adults who are able-bodied, without disability, and without children. So you might remember the Supreme Court ruling that happened last year on Obamacare. Of course, the states, I think Alaska was one of the 30-some states that sued. Alaska lost on the individual mandate question. But Obamacare now gives states the opportunity to either expand Medicaid or reject it. This is a map of what's going on around the country. And you can read this map like a stoplight. So green means go toward Medicaid expansion, and red means stop. So you can see by all of the green states, 26 states have now decided to expand Medicaid or are leading that way. 24 states, including Alaska, have decided to reject the Medicaid expansion, or they're leading that way. The big date that you need to remember is December 15th. That's when Governor Parnell releases his budget, and that's where we can expect to find Medicaid expansion or not. So with that in mind, I want to talk about 3 questions surrounding this Medicaid expansion. 1, how much is it going to cost? 2, how is it going to impact our healthcare system? And 3, what's happened in other states when they've decided to expand Medicaid to the Obamacare population? First, let's talk about cost. You know, during this time of year, I usually start planning my Christmas shopping, and I'm sure all of you guys are doing the same thing. Imagine if you had $200 to spend on Christmas gifts, but you don't know how many people to buy gifts for, and when you walk into the store, all of the price tags are blank. That is exactly the situation that states are in with Medicaid expansion. There are so many unanswered questions. We don't know how many people will sign up. We don't know how fast the Medicaid program will grow. And finally, some folks are saying that if we expand a government-run health insurance program like Medicaid, we will have savings, which is kind of counterintuitive. How do you save by growing government? Well, the reason is because they're using faulty numbers. They're saying that Medicaid expansion will be much cheaper than it actually is. So that's just the Medicaid expansion. This is a look at what Medicaid looks like today. It is a very expensive program. Since the year 2000, Medicaid spending has tripled. By the year 2030, it's going to triple again. Medicaid enrollment has grown 31% over the last 10 years. And Medicaid today is already draining resources for things like roads, schools, and law enforcement. Now, here's a picture of 2 kind of powerful guys in Washington. What do you think they have in common? Any guesses?
Jesus.
Well, I'll tell you what they have in common. The answer is that both of these guys have pledged to cut federal funding to pay for the Medicaid program. In his last 3 budgets, President Obama has proposed shifting more cost onto the states. In 2 of those budgets, he proposed what's called a blended rate, which would go back on that promise of a so-called free Medicaid expansion. In his budget, Paul Ryan has also proposed eliminating most Obamacare funds, including federal dollars for the Medicaid expansion. So remember this picture when people tell you that Medicaid expansion will be free. especially when both parties tell you otherwise. Let's talk about the second question. How will expansion impact our healthcare system? In other words, what does it mean to put 30 to 40,000 new people onto Medicaid? Well, here's what it means for people on the Medicaid program today. Medicaid is a pretty poor program. We know that people on Medicaid have difficulty accessing primary care and specialty care. Heck, the federal government's own data says that Medicaid patients are twice as likely as the uninsured and 4 times as likely as the privately insured to use the emergency room for non-ER care. So the next time you go to the emergency room with a sick child or a sick parent, consider that a lot of the people that you'll see around you are actually Medicaid patients who can't get in to see a doctor. Expanding Medicaid will only make crowded emergency rooms worse. Finally, we don't know if Medicaid really leads to better health. So many studies talk about this. But that's just for people on the Medicaid program. What does Medicaid expansion mean for people with private insurance? I think it might mean more people competing for fewer and fewer doctor's appointments. Alaska has a primary care shortage in 25 of 35 areas. Nearly 1 in 5 Alaska doctors are over the age of 60. The bottom line is that Medicaid has a really poor track record of improving patients' health, and putting 30 to 40,000 more people onto the program may just create further problems. Finally, I want to talk about a cautionary tale. You know, before Obamacare came along, there have been other states that have said, you know what, how about if we try Medicaid expansion? And you know what, at the Foundation for Government Accountability, where Josh and I work, we've looked at what's happened in all of these other states, because what's happened in these states could tell us what might happen here in Alaska. As you can see, we've looked at a number of states. All of these states have expanded Medicaid before Obamacare was even enacted. You can see it's a mix of small states and big states, red states and blue states. So what happened? Well, we hear that Medicaid expansion will reduce what's called charity care. Charity care is the bill that's left from the uninsured when they go to the hospital and they can't pay. What we found is that Medicaid expansion actually makes charity care even worse. We hear that Medicaid expansion will reduce what's called the hidden tax that Medicaid passes on to people with private health insurance. The logic is that the government can't pay doctors and hospitals what it costs them to treat a Medicaid patient, so the doctors and hospitals then pass on those costs to those of us with private insurance. But what we found is that Medicaid expansion did not reduce this hidden tax. In fact, it made it worse. We hear that expansion will be pretty inexpensive because all of these free federal dollars, but what we found is that in many states, Medicaid expansion cost way more than they ever expected, and it enrolled way more people than it ever expected. And finally, we hear that we need to expand Medicaid because there are too many uninsured people in this country. And I would agree that there are too many uninsured people in this country. But what we found from these states that expanded Medicaid, the number of uninsured people didn't change at all. Here's a look at what happened in Maine. You have to pardon, I'm a chart nerd. I can show you charts for pretty much everything. And this is a look at what has gone on in Maine. Maine in 2002 expanded Medicaid to the same population as Obamacare, so childless adults without disability. They said, if we expand Medicaid, we're going to help out charity care, we're going to help out the hospitals, and we will reduce the number of uninsured. Here's what happened. This is what charity care looked like. It actually increased fourfold after they expanded Medicaid. They estimated that about 11,000 people would sign up, that's the black bar. Out of the 14,000 people, that's the green dot, that they thought would even be eligible for the program. But here's who really signed up. In just over a year, twice as many people enrolled. The bottom line is that what Maine's experience tells us is that Medicaid expansion just doesn't work. We see the same in Arizona. Back in the year 2000, Arizona actually had a ballot measure that decided they wanted to expand Medicaid to, again, the Obamacare population, which is people earning up to the federal poverty level. The dashed line, that's a projection of how many parents they thought would enroll. Here's how many they thought were eligible, and here's how many signed up. Almost twice as many people signed up. Childless adults, same thing. Here's how many they thought would enroll. Here's how many they even thought were eligible. Here's how many actually signed up. Delaware, Oregon, and Arizona, again, tell us the same thing. The costs are astronomical. Here's a look at what happens after you expand Medicaid. Do you really cut the number of uninsured people? And again, of all of the states that we've studied, you can see that many of them had no change in the uninsured. Here's a look at health insurance coverage in Maine. You can see in 2002, they started the Medicaid expansion. In 2011, that's the last year for which we have data. The percentage of Maine's uninsured, that is the top bar in black, has remained unchanged. What you see is that more people have gone on Medicaid, that's the red bar, and less people have private insurance. That's what we call crowd out. Whenever you expand a government program, you have people who have private health insurance that may drop it in order to get on Medicaid. Arizona, it's the same thing. We've seen virtually no change in the number of uninsured in Arizona. You can see that again. More people are on Medicaid, that's the red bar. Less people have private insurance. If you look at Delaware and Oregon, the same thing. When they expanded Medicaid, no change in the uninsured. And after Michigan and Utah expanded Medicaid, do you know what happened? They actually had more uninsured people after they expanded Medicaid. So before I turn it over to Josh, I want to say there are many reasons to be cautious about this Medicaid expansion. We don't know how much it's going to cost. It's already an expensive program to begin with. It is very likely that the feds will shift more cost onto the states in the future. The Medicaid program today has problems with access and health outcomes. And then we have that experience of other states that have held a cautionary tale. So with that, I'll turn it over to Josh, and then we'll take questions. Thank you.
Well, again, I just want to add my gratitude for you all showing up tonight to learn a little bit more about this law and what is ahead. I think what's been very interesting about this whole debate is that we've had 3.5 years of very partisan rhetoric, and the rubber's hitting the road this year. And for those of us that are trying to decide, how does this impact me or my neighbor or my grandchild or my son or daughter, this is the opportunity in a very short window for us to decide, what do we need to do, or how is this going to impact me? And it's hard to get good information. So it is just a real pleasure for us to be here and have a chance to chat with you all and share some of our research. I mean, we often have pencils behind our ears working away, and so it's great to be able to come out and have some conversations and hear your stories. So we look forward to the question and answer. What I'm going to talk with you all tonight about is 3 things: the exchanges, the tax credits that are available in the exchanges, and the IRS. Now, just before I start, I want to add one caveat here. If you're on Medicare, almost everything I'm about to say does not apply to you. I'm happy to talk about how the Affordable Care Act or Obamacare impacts you, the Medicare program, during the Q&A. Or if you're in the VA system in TRICARE, signed up for TRICARE, this also does not apply for you going forward. But I just wanted to make sure that we had that on the table before we go forward here. So let's start and talk a little bit about the exchanges. Here in Alaska, the state decided not to set up a state-based exchange like a few other states have, and so the federal government is running the exchange. And for anybody that has a television or been reading the newspaper, you know it hasn't been going very well lately. I think the last number I saw was 7 confirmed enrollees in Alaska going forward. So this is not the rush of enrollment that they had hoped for. Now, the projections in the state for the first-year enrollment in Alaska are 19,311. So we are a little far from that eventual first-year goal, and we'll have to wait and see once they fix the website, can fix the website, what will come of that. People have been spending weeks just trying to create an account in the state, trying to get on to figure out what sort of products are on there. But yet the website is not the only issue. there have been deeper problems that have come to light in almost every single stage of the enrollment process coming forward. So I don't think we've seen the end of the stories that we've heard of people having a challenge trying to enroll, or even to see what options there are there first. I mean, we just found out, I believe it was last week, that in the first day of enrollment nationally, there were 6 confirmed enrollees. So this has not just been a problem in Alaska, it's been a problem in a number of other states, regardless of whether you have a state-based exchange or whether you have the federal government running it for you. I just wanted to highlight some of the issues that we do have going forward on this. This is a very complex system that they've set up. And from a technology standpoint, it's almost a nightmare. You have systems like the Social Security Administration using a computer system that was built in the 1970s, trying to interact with the technology and website contract that the contractor set up for the federal government. So again, I just wanted to highlight that to say, I think we haven't seen the end of some of the enrollment problems going forward. We've seen insurers receiving incomplete applications or duplicate applications, people receiving eligibility forms for another individual from a different state, or being told to call into the federal government with a registration number, but never receiving a registration number to reference. And after all of this, we've learned that almost all of the new enrollees have been on Medicaid in almost every single state. So it's not people buying private coverage in the exchanges, it's people enrolling that are currently eligible for Medicaid, or in the states that have expanded, it's people that are in those expansion categories that have signed up. Something that you're now familiar with in Alaska, a rash of cancellations of those of you that have individual policies. I know that Premera Blue Cross Blue Shield has canceled over half of its individual policies in the state, and Aetna has not released their numbers, so we don't know the full extent of this going forward. And as you've seen in the press, this has certainly put into question the President's promise that if you like your health insurance, you can keep it. I want to make sure that people understand that there's no trial period in the Obamacare exchanges. If you decide to enroll next year, it's not like you can easily go back. Well, first of all, you're in for the whole year. You can't switch back to the policy you had before. And with the rash of cancellations, it'll probably be impossible to switch back to your plan before. But the plans are changing going forward, and there's some insurance executives that I think were quoted in the press last week that's very telling. They said people should understand that in 2014, the insurance industry is changing drastically. And in 2015, it'll change drastically again. So for us to feel like we know everything that's going to be happening in the next year or two, I think we have yet to see all of those changes coming down the pipe. There have been some deep privacy concerns in the enrollment process, and this goes from filling out the application all the way to the federal government. And I wanted to spend 1 minute here highlighting a number of these. The navigators are a part of the Affordable Care Act. The federal government set aside money to hire in Alaska's case, 2 organizations, United Way here in Anchorage, and the Alaska Native Tribal Health Consortium, each given $300,000 to help people enroll going forward. Now, I'm not calling into question the integrity of either of those fine organizations. However, I will say that those individuals who are trained as navigators had very little training. They had no requirement for them to have any sort of background in health insurance or health care. They will be learning about the plans on the exchange along with us if we're shopping for them, and they'll only know information about the government exchange plans. They won't know about what's on the private market outside. So if that's the more appropriate option for your family, they simply won't know anything about it. So I do think for individuals that are thinking that are enrolling and dealing with navigators, there's some serious concerns. There's been some press reports even today about navigators telling people to lie about their income or to not be as forthcoming as they should be on their applications to try to get extra money out of the federal government. I think this is due to the minimal amount of training going forward and the fact that there's no sort of background check required for somebody to serve as a navigator. Some of the exchanges have already been targeted by hackers in the state of Connecticut. They confirmed that 5 attacks have come in the last 2 weeks against the exchange. And individuals have said that the federal exchange, likewise, will be a prime target for hackers going forward, given the amount of data and information that will be available on that. Now, part of the reason that is because so many people will have their hands on an application as it goes through the process. You may start on a computer, or you may start with a navigator with a paper application, and you fill that out. It will then have to go to 5 federal agencies through their data hub. It'll have to go through some state agencies through that process. And the sort of information that's on that application is, and just to give you a flavor here, is your name, social security number, home address, date of birth, marital status, family structure, information about your children, income level, employment status and hours, insurance information, citizen status, disability status, partial medical history, including whether you've had problems paying medical bills, education level, race, sex, email address, phone number, foster care information, pension information, retirement account, social security payments, alimony payments, investment information, and if you're self-employed, the list goes on and on. The application's quite long, it can be 5 to 21 pages. The reason I go through that laundry list of information is not because you necessarily need to know that, it's all laid out in the application, but anybody that sees your application will have all of the information to defraud you. Now, 13 attorney generals across the country have written to the federal government saying, you simply haven't done enough on privacy to protect people's information going forward. I think there's a deep concern about this. I suspect there's already been one arrest in the state of Maryland for a navigator stealing information, and there's been more and more accounts of people getting called at their home or knocks on their door saying, I'm here to enroll you in Obamacare, I need your personal information to do so. So there's serious concern about privacy here going forward. As I mentioned, quite a long application depending on your life circumstances. So let's talk just for one moment about the actual products that are in the exchanges here. And I decided, well, let's look for Anchorage, if you were a younger adult, what you would be paying pre-Obamacare and post-Obamacare. So we now have a general sense. And I went on ehealthinsurance.com, which is a website where you can purchase insurance. And I said, for an average 27-year-old in Anchorage, how much could they purchase a plan that starts December 1st of this year? And plans ranged anywhere from $77 all the way up to $306. So there's a little bit of a range, averaging about $150 going forward. Post-Obamacare, for that same individual, the cheapest bronze plan, where there are these metallic levels in exchange, the cheapest bronze plan for those individuals, $385. It's a 139% increase. Now, to be fair, younger folks will probably see the highest premium increases under the law, and some of them may even qualify for tax credits. But here's why this matters. If you're not a 27 or 30-year-old, you may know one. That may matter to you. The second one is that if those individuals don't sign up, everybody else's insurance in the exchange will spike as a result. You need to have the young people to sign up for them to be able to make this law work. The administration, the Obama administration, says they need 2.4 million young people to sign up for this law to be financially sustainable. I would love for you to ask a 27 or 30-year-old that you may know in your life, is $385 affordable for you? These are people starting usually at the beginning of their careers, making the least amount of money, versus somebody who's later in their career making the top, for most of them, the top of their earning income. This is a serious problem here for the law and whether it will be sustainable and having young people sign up going forward. Talk a little bit about the actual insurance products. There were only 2 of the insurance companies offering on the Alaska Exchange. Aetna has chosen to not participate. Now, I think why this is of note is that one of the promises of the federal law was we're going to see a lot of competition in the exchanges. We're going to see a lot of insurers offering a lot of products, and that's going to drive insurance rates down. I think that has not come about here in Alaska and a number of other states going forward. As a result, in most counties, you're only going to have one or maybe both of the insurers offering. And as a result, you can see in the prices, it's a lot more expensive. But one of the ways they've tried to keep prices down a little bit is that they've cut out doctors. And we don't know the full extent of this in Alaska, but we have started to see snapshots around the country of the exchange plans. And I'll just give you a few examples. In the state of California, The exchange plans, on average, offer about a third to half of the amount of doctors that you would have on a typical private plan outside. They typically cut out the more well-known hospitals, again, to try to contain some sort of the cost for the premiums, even though we're seeing the $385 cheapest plan for young people. And sadly, in a state like Alaska, the New York Times did an analysis and found that in rural settings, those are the individuals that end up paying the highest in exchanges. So in a more rural state like Alaska, because there is not the kind of competition that was promised, those rural individuals pay a lot more for insurance once they're in the exchange. I think a deeper concern here is whether doctors will participate and take the plans. We still don't know in many cases whether doctors will accept them or not. There's been some recent national surveys of doctors, and the most conservative one was that 30% would definitely participate and take the plans. 30%. That means all the rest of the doctors are holding out saying, well, I want to see how much I'm going to get paid. And in the states that have released the reimbursement rates, it looks a lot like Medicaid. You have an access issue already, where doctors aren't taking Medicaid. There's a real question if you sign up for exchange plans, whether you'll run into that same issue. There's been other surveys in the state of New York that show much worse, a much dire situation than even that national survey going forward. But I think all of these raise an issue and a concern about future access going forward. Even if you have an insurance card, can you actually see a doctor? Because the card isn't worth much if you can't actually find a doctor. And the concern here, and I come from Massachusetts. I've been living in Massachusetts, so I've seen this play out over the last few years in our reform in this state. And those individuals that are on the exchange plan still show up at the emergency room at the same rate that people in Medicaid do. So it raises this question about, do you really address the uninsured question if those individuals can't find a doctor and still go to the ER going forward? Final thing I'll highlight here on exchanges is that they can change the rules anytime. They can decide, for next year, we're going to require insurance plans to only cover these sorts of treatments. Or if they're going to offer that treatment, they have to follow these sorts of guidelines. Again, I come from Massachusetts, I've seen this play out, I've seen the governing board of our state-based exchange make these decisions going forward. And there was already the groundwork being laid. The New England Journal of Medicine had an article by two academics laying out, here's the pathway forward for exchanges, how you can play a more activist role in changing how people receive their health care going forward. So it is at the mercy of those that are running the federal exchange or a state-based exchange to determine how they want to set those up going forward. Move on briefly here to our second topic, which is the tax credits that are available. Now, any argument of affordability in the law is built on these tax credits, saying, well, you may be lower income, insurance may be much more expensive after Obamacare goes into full implementation, but at least we'll give those people some sort of tax credits. And in a state like Alaska, where you've decided not to expand Medicaid, those will be available for those making between 100% to 400% of the poverty level. As Christy mentioned, that's for a single person about $14,000 to about $56,000. And then for a family, that's $29,000 to about $116,000. It's based on a sliding scale, based on your income. It's based on your family size going forward. Now, these are not available if you have, quote-unquote, affordable employer insurance, or if you're on Medicaid or Medicare. So these are just for a certain subset of the population going forward. I'm happy to talk a little bit more about that affordability standard, if you will, Q&A for now. I'll keep moving on. Now, the credits can only be used in the government exchange. They can't be used on a private exchange. They can't be used with your current plan. You have to switch and go into the exchange to be able to use the credits. And you must file a tax return every year. If you fail to file a tax return claiming the tax credit, then you lose your ability to claim it ever again in the future. Now, why does this matter? You can't switch back to your old plan. It no longer exists. It's changed. And you're therefore stuck, even though your income is lower, paying the full cost of the now more expensive insurance going forward. The tax credit will be based on your income. You're going to have to guess your income for next year. Now, the law assumes people's lives are static. And I think as everybody in this room knows, their life is not static. They get married, the kid goes off to college, they get a promotion, they get a new job. And as a result, for those, especially in a state like Alaska, where you have so many seasonal workers or those that are in tourism, this is nearly impossible for them. To say, next year I will definitely make this amount of money. And if they misestimate and they get a promotion or get a new job, then they may end up owing the IRS money, which we'll get to in a second. You can take the tax credit in advance. And again, you may end up owing the government money if you take too much. You can take a partial credit, or you can claim it on next year's taxes as a tax refund. Now, I think that's highly unlikely because you have to come up with the full cost of the insurance plan on your own up front and then claim it later. I think most individuals don't have that kind of money sitting around spent on health insurance. And as I mentioned, these very minor life changes could have a tremendous impact on your tax liability for the health insurance to the IRS going forward. And I'll give one example. In the state of California, they looked at the population that qualifies for these individuals. And that what they found out is that those folks tend to have a very volatile income. And what they've asked you to do is to call them every time you have a life event happen. Every time you're supposed to call the exchange and say, my kid's going off to college and taking the student health plan. I'm getting married. Even if you do that, even if you call every single time, in California, almost 40% of the population still would owe the IRS money at the end of the year because their life changes would make that possible. So we have a real question here about whether individuals understand the relationship that they're entering into with the IRS going forward. And I do want to spend and just close a little bit on talking about everybody's favorite federal government agency, the IRS. Now, the IRS will play a pretty big role in Obamacare. They have 47 separate tax provisions, and largely they revolve around the collection of 18 new taxes. It's about $1 trillion over 10 years, and that money is used to try to fund the tax credits. That's how they're trying to pay for it. And we've perhaps heard a little bit of discussion about the controversial individual mandate. You have to purchase insurance. But actually, in the law, the IRS's role is restricted. They can't really, their hands are a little bit tied in going after you for the penalties. However, for the tax credits, they have their whole toolbox if you end up owing them money come next year. And that could be a few $100s, or that could be multiple thousands of dollars. For those individuals that are right near that top 400% federal poverty level threshold, if they make $50 more or $100 more and go over that amount, you have a kid who gets extra hours around Christmas time and that's added to household income. You go over that income cliff, you owe the federal government the entire value of the tax credit. And for families, I mean, that's $13,000, $14,000, $15,000. I certainly don't have that kind of money sitting around to just have to pay the IRS. I don't think a lot of individuals will either going forward. But because we're a think tank, we decided, okay, this is what the law says. Are there past experiences for us to learn from? Do we have any precedent for something like this? So it raises this first question of, will people actually file that form? Have to file it each year? So what we decided to do is go back and look at a tax credit that was somewhat similarly structured to this. It was called the Advanced Earned Income Tax Credit. You don't even have to worry about what it does. I'm happy to talk about it later if you're curious, but it's been repealed, so it's not as relevant now. But that program also required beneficiaries to claim the credit every year. They had to file an additional tax form. Now, what the government auditors found was that 80% of people who filed had some sort of problem with the form that they actually filed. But that's not the major takeaway. 40% of people never filed. So I think it raises big questions about whether individuals will end up a creek without a paddle because they forget to file it, or they weren't told they need to file it, and again, they lose the ability to claim it going forward, and there's ample precedent here going for that. I raised some concerns about privacy earlier. whether the IRS or others can keep your information safe. And I do think that there is some troubling anecdotes. They are anecdotes, but anecdotes usually point to some underlying issues. Just recently about these government agencies keeping your information private. I'll just read a handful of them to you. An employee at the Minnesota State-Based Exchange sent a file containing 2,400 names and social security numbers to a health insurance broker by mistake. Last year in South Carolina, the IRS was blamed for contributing to a data breach that exposed 3.8 million taxpayers' social security numbers, credit card numbers, and bank account data. Hackers were able to access personal information of 780,000 residents in Utah, including their names, addresses, date of birth, medical diagnostic codes, among other information, and 280,000 people had their social security numbers stolen. In July, it was reported the IRS had posted 100,000 social security numbers online by mistake. And a lawsuit in California has been filed against the IRS in which 15 unnamed agents seized 60 million medical records of 10 million Americans in 2011. Again, some troubling anecdotes that I do think lead to some concern for those that participate in the tax credits. However, there's also a concern here about how they run their audit process. If you owe the IRS money, they can audit you. That's one of their functions. Again, we looked at the past and said, what's a similar type tax credit of a similar value, and is there any lessons that we can learn from this? The adoption tax credit. Widely popular, bipartisan support for such initiative. Again, the tax credit runs anywhere from $10,000 to $13,000, roughly equivalent to what some of the tax credits could be here. The IRS's own internal watchdog wrote a scathing report. I actually was quite surprised by the tone of the report. 70% of families that participated in the adoption tax credit were subject to an IRS audit, routinely lasting years. She wrote, the IRS's implementation of the expanded adoption tax credit does not bode well for its implementation of the premium tax credit, the tax credits that we're talking about. She connected the dots for us. If the IRS does not take the time to learn from its adoption tax credit experience, be thoughtful about how it administers future refundable credits, it may face problems with the premium tax credits. It will overwhelm IRS resources and severely burden taxpayers. Now, the IRS's response to the scathing report was, well, we didn't want fraud. Fair point. However, her response was, for the IRS to say with a straight face that this is a positive result of any audit strategy makes a mockery of effective tax administration. It also signals that the IRS continues to underestimate or ignore the true burden it placed on taxpayers. Again, a concern here, the IRS has requested 2,000 additional agents to implement the federal law, and the Obama administration filed $440 million additional dollars in their last budget for the IRS going forward. Now, what's very interesting about this is that Congress can change the law, and has changed the law when it comes to the tax credits. In fact, they've already done it twice. It's not really known. I think we're up to 20 changes in Obamacare so far, and 2 of them were to increase how much individuals had to pay back if they got too much tax credit. To Christie's earlier point about Medicaid, where the rhetoric coming out of Washington is not, give more money to people. It's, oh, we need more money to pay our $17 trillion debt. And that's one way that they've chosen to do it, is to make people pay back more money if they misestimate their income going forward. And my last point, I just want to talk a little bit about what the IRS's toolbox actually looks like. Perhaps some of you in this room have had an experience with the IRS going forward. We've had dozens and dozens of conversations with people all over this country who qualify for the tax credits, who have told us horror stories about their past experience with the IRS. When they learn about the IRS's involvement, based on their past experience, they say, look, I'm gonna stay out for 1 more year. I need to see how this plays out. I'm uncomfortable with the role that the IRS will play. Now, if you can't come up with that $12,000 or $13,000, if you go over that upper income level, the IRS usually sends you a letter, perhaps sends an agent to your door saying, we need to work out some sort of agreement. And largely, you're at the mercy of the agent that has your case. Now, if they don't like your repayment plan, they can put a lien on your house, they can levy your wages, take money out of your bank account, They can assess you penalties, late penalty forward, and very quickly that maybe $600 or $2,000 that you owe the IRS can escalate going forward. All the while you're trying to figure out, should I be in exchange next year or not? I owe this back money, this doesn't seem like a good deal. How do I estimate my income better for next year going forward? So I do think that whether it's yourself or other individuals in your family that are considering looking at the options and the exchanges, they need to fully understand this relationship that they're entering into. And we simply have not heard anything about this in the media. All we've heard is the tax credits are great, it makes insurance more affordable, but that assumes everybody's life is static. And as I think we all know, that's simply not the case. And I'll throw one last wrench in here. There is another lawsuit around the tax credits that may eventually end up going to the Supreme Court. And it comes out of the state of Oklahoma. And the argument of the case is, if you don't have a state-based exchange, there's nothing in the law that allows the administration to offer tax credits in a federal exchange. If that case does make its way through, and that is the ruling of the court, then tax credits won't be available in a state like Alaska that doesn't have a state-based exchange. And I think there's big open questions about the sustainability of the law if you don't have people signed up going forward. And so I think that is a big open question here going forward. I did want to offer just one resource. We have a website that we have launched. It's called Uncover Obamacare. This has our research. It lets you understand the tax credits. We wrote a report explaining the tax credits, but also telling stories about average Americans and how the tax credits could play out in their lives for these very common life events. We have some Medicaid expansion research on there. We will also have a more detailed report on the IRS's involvement. And again, for us, Uncover Obamacare is a little bit of lifting the lid, trying to see what's underneath and understand how it's all going to actually impact individuals. And so I really appreciate the opportunity to be here tonight, and I look forward to any questions that you may have going forward.
I have one statement for Josh here. I'm from the IRS. I'm here to help you. I used to be on one of the Air Force's IG teams, and that was our motto as well. Nobody believed it, by the way. You all remember about a week ago, last Saturday, the honor flight of World War II veterans returning from Washington, D.C. to visit World War II Memorial. Alaska really loves its veterans. And it was a great experience in watching. They had a band there, they had a bagpiper, and the great turnout. Anyway, it was a great experience to see them coming back, and Alaskans. But I love the veterans, they just showed so much gratitude. There were younger people, there were older people, a band, Scottish bagpiper. And what I'm leading up to is, you know, with the expansion of Medicaid, we have some very unintended consequences that may occur here. This shows you an example of Alaska's reimbursement rates to physicians. Now, these are not exact dollars. These are actually percentages, but I've used $100 as a baseline. If you're a senior, how many people in here are seniors? Don't be embarrassed, ladies. We won't tell. And how many are veterans? Great crowd. Anyway, you're going to be affected. There's some unintended consequences. A senior goes to see a primary care physician in town, and the reimbursement rate from the federal government, let's say, is $100. If you're a veteran or you're a dependent, you're covered by TRICARE. That's if you're a veteran that's retired before your age of 65, which is an HMO type policy from the Department of Defense. The reimbursement rate for you is $137. But let's look at the Medicaid person. The Medicaid person, the reimbursement rate for that same primary care physician is $147. So you got those three people trying to get into the doctor's waiting room. Doctor's a business person. They have to be. The practice has to be successful or they're not going to be around anymore. The Medicaid patient is going to be seen first. And maybe the TRICARE patient. The Medicare patient is probably going to have to sit on the curb outside the doctor's office. Now, I have to say, there are a lot of physicians in this town that do take Medicare and TRICARE. Kind of like a charity case, though. Anyway, that's where we're headed. Now, Christy mentioned, I believe, 2011 Medicaid spending in Alaska, $1.4 billion. 2014, it's $1.6 billion. Substantial part of the Alaska budget, about 1/6. You see the red line on the bottom? And the green line, not the one way on the bottom, the red line and the green line. We always hear about PERS and TERS, the unfunded liability. Well, these are the annual payouts for them. The big blue whale that you see in the middle, gobbling up the entire graph, that's Medicaid payout per year. So we just cannot sustain payouts like this. You're going to have to eat up the education budget, maybe transportation, and some of the other ones you can't eat them up because they're not disposable as such. So the Affordable Care Act, as Josh said before, it provides health insurance. It does not provide health care. You'll have an insurance policy, doesn't guarantee any access. Matter of fact, we probably have a big supply and demand problem in the country with health care, and particularly here in Alaska. You need to get informed before you opt in. And Chris and Josh have given us some great information and some fact-based information and research-based. It's your health. You owe it to yourself and your family to get educated. Here are 3 websites: Alaska Policy Forum, Americans for Prosperity in Alaska, and the Foundation for Government Accountability. Go to these websites if you have any questions, particularly the last one. These folks sitting right here, they're the healthcare policy experts. And with that, we're going to have a Q&A session, and we'll have mics passed around. Please keep your questions as short as possible. And let's give another round of applause.
My question is that I would like you to also address healthcare costs, because you're dealing with this in isolation. I was wondering why there's not more information on the healthcare costs and how that's contributing to so many of the statistics and so on and so forth.
Yeah, I mean, I think you're actually raising a very good point, which is Obamacare largely doesn't address that issue about increasing healthcare costs. In fact, it doubles down on a lot of the perverse incentives that currently are in the system. Now, if we want to kind of go broader, we could argue that some of the pilot projects in Medicare may eventually lead to some sort of cost control. But I think you're raising a very good point. And that's our point, which is Obamacare doesn't fix those underlying problems of higher costs. And I don't think Christy or I'll let Christy speak for herself, we're not trying to blame consumers here. There's probably enough blame to go around for everyone on this. I think Christy and I spend most of our time talking about reforms. How do you get to that day in which consumers are empowered to be value seekers? That they find where the best quality, lowest cost care is. We're very far from that day. I think some states may be a little bit closer to that than where we are. But I think for us, the bigger concern under Obamacare is you really don't get to any of those issues. You simply throw more people into a system that have some of the problems that you highlight. So I do think, I mean, again, I come from the state of Massachusetts. They have had a huge cost problem. They just passed a bill in which they basically have set price controls. We've tried that in the past. It hasn't worked, but yet they're going to try it again. So I do think that there is some deep concerns about this, and from our perspective, that is missing the point to a certain extent because we have not addressed that through the federal legislation. I don't know if Christy has any additional.
Thank you for your question.
Yeah, I had 2 questions about the penalty phase here. We all know that young, healthy people have to get into the system for it to work, economically, financially. But I've been told that there's very few enforcement mechanisms for actually enforcing the penalties. And I wondered if you could elaborate on that. And then second, I heard George Will say the other day something I never realized before. And I haven't read the actual Supreme Court decision. I just got so discouraged by it that I didn't go read it. But that in the decision, that if the penalties were raised higher to the actual level of the costs related to it, to actually get more people to actually get into the system, then that would be unconstitutional in the decision, because then it would be a tax. The only reason it was ruled it wouldn't be a tax, and it'd be a penalty, and they didn't have the authority to do a penalty. Maybe you could explain that, because I didn't know that was an issue out there either.
So I'm not a lawyer, so I will not speculate on those fronts, but I did see the George Will column, and it is an interesting point. It was the argument of the Chief, actually it wasn't just the Chief Justice, it was almost all of the court that basically agreed on that point, that because it wasn't a coercive amount of money for the penalty, it was a fee. You know, and they had this threshold by which they felt like if Congress went back to change the level amount of money, then it would be constitutionally a different scenario. So we'll have to wait and see what happens. I think politically at this point, if they were to go back and raise the penalty to $5,000 or $7,000, whatever level that is, that would be a tough sell, I think, politically. So we'll have to wait and see. If people don't sign up, then supporters of the law will have to assess their few limited options going forward about how you get people into the system. Now, there are two places in the country in which the way they've addressed this, and this is again to the point that exchange can change the rules at any time. In the state of Vermont and in Washington, D.C., they are forcing everybody, every single person under, or works at a company under 50 or buys insurance on their own, to purchase through the insurance. Purchase through the exchange, excuse me. That's your only option. Now, Vermont has a single payer vision. I'm not sure that's where Washington and DC is right now, but for them, the way that they were going to fix this problem of a lack of participation and just say, you're forced to come to us, you have no other option.
What's the issue with the weak enforcement of the penalty?
Well, when Congress passed the Affordable Care Act, there's statutory language that basically says that the IRS can't use all of its toolbox. It can take the money out of a refund, the penalty, the value of the penalty. If you file a form, your tax form, then you would receive a due or refund, they can take it out of that. But largely that's the extent of their enforcement. So there's a lot of people who are trying to very creatively think about how do I not file a tax return where I don't have a refund and then they can't take it out of the refund. But to me, this is, again, missing the point. If the point of the law was to increase coverage, why are we incentivizing tax advisors to help people figure out a way around it? That seems to be a very big unintended consequence going forward. So we'll have to see what happens in the future when it comes to the level of penalty.
I pretty much solely focus on Medicaid. This is not really my area. Woo, hot mic. But someone sent an email to healthcare.gov, and it talks about the exemptions from the individual mandate. So the individual mandate does not apply to you, and you can qualify for an exemption if you're homeless, if you were evicted in the past 6 months, or if you were facing eviction or foreclosure, if you received a shut-off notice from a utility company, if you recently experienced domestic violence, if you recently experienced the death of a close family member, if you experienced a fire, flood, or other natural or human-caused disaster that caused substantial damage to your property, if you filed for bankruptcy in the last 6 months, if you had medical expenses you couldn't pay, if you experienced unexpected increases in necessary expenses due to caring for an ill, disabled, or aging family member. I mean, you could drive a truck through a lot of these exemptions. You know, there are some eggheads in Washington that talked about the increase in the Amish community that might come about because of the Affordable Care Act, because they are exempt from the individual mandate. But looking at those exemptions, I mean, if you face, you could have your utilities shut off purposely and maybe qualify for a hardship exemption. So it's going to be very, very interesting to see how all this plays out. I think it's healthcare.gov/exemptions.
And just relevant to Alaska, if you're a native Alaskan, then you are also exempt from the individual mandate going forward.
We can hear you.
I'm Rob Peterson. I'm a neurosurgeon. I've been doing this for about 30 years. I've also practiced in Britain, and I work with Canadians. We've not spoken much about the 40 or 50 million people that can neither afford health care nor can afford health care insurance. And I was wondering what the counter proposal would be.
I think by and large, Medicaid really isn't the program to do it, especially for low-income folks. I mean, there are so many doctors who don't take Medicaid patients, not only because of the reimbursement, the low reimbursements, that's obviously not the case here in Alaska, but because of the paperwork that's involved. I think you can't put more people into a poor quality program and expect results. I think the first thing that probably should happen, and there's been bills filed in Washington to deal with this, is if you have the plan right now, you can keep it. And that's something that's moving and has bipartisan support. I think for folks with pre-existing conditions, we had something called high-risk pools. About 35 states have them. Alaska was one of them. It's a way to extend affordable coverage to people with pre-existing conditions that could not buy insurance, and it caps the amount of premium they can pay. Those all went away because of Obamacare. I would love to see those come back and maybe take care of the folks with pre-existing conditions. And finally, I think, you know, if you buy health insurance coverage, if you get health insurance coverage through your job, you get it with pre-tax dollars, but if you buy it on your own, you pay for it with post-tax dollars. And some of the things that states are doing they're talking about giving an individual income tax credit for folks who buy health insurance out of pocket to kind of equalize the tax treatment. Mandates are another thing that drive up the cost of health care. Medicaid reform is the other thing. You saw the Medicaid chart. You know, it's tripled since the year 2000 in Medicaid spending. And by the year 2030 in Alaska, it will triple again. And so talking about some patient-centered reforms, I think, would take care of that well.
So you're saying that you would put all the people, the tens of millions, you would put them on Medicaid?
No, I'm not.
What would you do with the tens of millions of people who can't afford health care insurance and can't afford health care? If we allow them to see doctors or police doctors, and if we allow them, who's going to pay for it?
Sure. I think you have to look at the uninsured as not as a monolithic problem. Many reasons why people are insured. They can't get it through their employer. They just came to the country. I mean, there are so many different reasons why folks are uninsured. So I think what you have to do is look at a myriad of options, like the ones I just described, and kind of take off little chunks. You can take off $1 million here, $1 million there, or some of these targeted solutions. And that's how you move forward. I think part of my frustration with the healthcare law is this kind of one-size-fits-all structure. You know, if you make this, you're going to be on Medicaid. If you make this, you're going to be inpatient. Why not have some more targeted solutions? And I think a lot of times when that happens in Washington, when there's a big, you know, Washington, D.C.-based solution, it kind of crowds out the air in the room for all the other things that could have been done. Josh, anything to add?
Yeah, I just think it's important to remember that when all is said and done and Obamacare is fully implemented, 30 million people will still remain uninsured. This is not a universal health care type proposal that some talk about as. So if we are concerned about the uninsured, as I think we rightfully should be, you still have the problem under Obamacare for 30 million individuals. So from our perspective, we have said the stated goals of getting more coverage. Is it a cost-benefit analysis? Is it worth the disruption and the additional taxes and all of these unintended consequences? And from our viewpoint, I think we're really concerned about it. I don't think, as Kristen said, how you tackle uninsured in Massachusetts is the same way that you tackle getting coverage for the uninsured in Texas. The industry mix is different, the income level, the geographics are different, the medical infrastructure, the education level, it goes on and on and on. And so I think we have spent a lot of time thinking about this issue. And I think some of it, as you know, has to do with delivery reform. Some of it has to do with how our insurance is set up. Some of it has to do with we need to understand how much things cost. We need to, as consumers, play a different role. And there's a lot of proposals that some are happening at the state level, some in DC, that are part of that. Some of them are happening in the private sector that I think we need to fully explore. Because if you get the cost of insurance down, then those individuals are much more likely to purchase it than now, where it's simply unattainable. And our concern is that Obamacare makes it even more expensive to get insurance. And so it's going to be that much harder for those individuals. And over a longer term, you may not just have 30 million uninsured, you may see 40 million and see it creep back up. We've seen that to a certain extent in Massachusetts, that people are still showing up in the emergency room and the state is still paying for uncompensated care, even though that state is claiming that we have 97 or 98% coverage. Something's not adding up here. And we've seen it in Medicaid expansion, we've seen it in Massachusetts. I suspect we'll see something similar to the federal law 5, 6, 7 years out. So I appreciate the question. I think it's a very valid discussion. But as Christy said, once you take a one-size-fits-all approach, I think you've lost the argument.
Okay, we're going to go over here. We're at one back and see a few other hands over on this side.
In the exchange, you said that there's no trial period, but what if you have a qualifying event where somebody having a new child or they recently got married, do they still stay in the exchange or can they opt out of that?
Well, typically we tend to think of qualifying life events as an opportunity to sign up. So if you are already signed up, let's talk about getting married, for instance. So if you are signed up, if the couple is engaged to get married, and they both are in the exchange, they both can claim the tax credit. And once they get married, as soon as they call the exchange and tell them that they got married, there's actually a marriage penalty. So their collective tax credit is now worth, I've seen examples, $4,000, $5,000 less. So that's a qualifying life event. Their insurance changes from the perspective of that they now have to pay more for insurance because they're married. So, I mean, I think that this is a good question. If you lose a job in the middle of the year, can you then sign up for the exchange? My understanding is you can. Those are the few, and it's spelled out what those qualifying life events are that you're allowed to do. If you leave you're on exchange insurance, and you get a new job, you can make that smooth transition if you call the exchange right away. If you don't call the exchange right away, they're going to continue to pay the insurance company your tax credit, and come tax time the next year, you're going to owe them back that money.
I do have one other question. You had mentioned that Vermont is actually not offering insurance, is that correct? That they're forcing them to go to the exchange? Isn't it true that the employer does have to offer insurance to each employee? And if they do not elect it, that they do go to the exchange, that it's cheaper for the employer to actually pay a penalty if they had not offered the insurance.
So it depends on the size of your company. The federal law says that if you have 50 full-time equivalents, employees or more, you have to offer insurance. For those under 50, you don't. Now, there's very complicated formulas about if you offer insurance and somebody goes and gets a subsidy, then you're fined this way, or if you outright drop insurance, you can just send everybody, and then you would be fined. In those cases, the math is different for different companies, but there has been a concern that for a lot of companies that are running the math, and I talk to a lot of health insurance brokers, just like what I do, I guess, and for them, they're running, for companies over 50, running 4 or 5 different scenarios. And they're saying, if you drop coverage, how much would it cost you? If you keep coverage, how much would it cost you? Go through all these hybrids of variations of that. And for some of those companies, it will be cheaper for them to drop their employees' insurance, to send them to the exchange to get some sort of coverage, and possibly give a raise to those employees. Now that sounds great, except if you're a federal taxpayer, because that increases the cost of the law twofold, probably. And just again, I hate to keep bringing up Massachusetts, but this is a big difference in the law. In Massachusetts, if you're offered help employer-based insurance, can't get a subsidy. End of story. Under the federal law, totally different scenario. I expect you're going to see employers act very differently under the federal law than they did in Massachusetts. And as a result, the law is going to cost a lot more.
And we probably won't see a change because there is a delay in the employer mandate. So, individuals don't have that delay that employers do. So this is going to be a problem like a year down the road.
That's right. And the cancellations that you've seen in the individual marketplace, those cancellations are coming for small business next year. Because their plans, because they've been given this extra time period, will not be compliant come 2008 to 2014. And a number of them will see their policies canceled. So you can look for that in the news coming next year.
Okay, anyone in the back here?
Josh, you and the other presenters did a good job of making me aware of the long-term really have no. Can we count on you and the other presenters to refuse to participate in this program and sign up?
Yes, but because we are on employer-based insurance, or I speak for myself, I'm on my wife's insurance. So for those individuals that are on employer-based insurance, this is not a decision unless our employer drops coverage that we're going to have to make. So yes, for me, just because of my current situation. I think if I were considering this decision, I don't think you should just trust me. I think you should go talk to an insurance broker. These are individuals that it is their livelihood to give advice on what is best for you. And they should, if they're a good insurance broker, look at your life circumstances, should know some of this information that we presented tonight. Now you can maybe present some to them, and try to figure out what's appropriate for you. My biggest concern is that if you're on private insurance right now, if you drop that coverage and go into the exchange, you're going to run into a number of these issues I've highlighted tonight, and I don't think a lot of people know that. They don't know that if their doctor is in their plan or not, because that functionality of the website isn't working. So if you really need X doctor, or you want to go to this local hospital, you're going to have to spend a lot of time in the exchange getting a straight answer for whether those two things are in your network or not, because we just simply don't know that information. And we're looking at a very small time window for people to try to make these decisions, and I simply don't think they're going to have all the information. I think that's really unfortunate.
Just as an anecdote, the IRS, is your understanding that one of the first things they will do if you don't have adequate tax refund, they will take your permanent fund dividend, as they do with many people, even though they promise they won't?
Yeah, I mean, this is a great question that is particular to us. You know, I'll have to give it a little bit more thought. I'm happy to follow up with you afterwards, whether in the law the IRS has the ability to go after that. I think if you owe the tax credit, if you entered the exchange, that is, you know, kind of on first blush, you're going to look at it again, would seem to be very reasonable. It's considered an asset for you, and it's something, if they can garnish your wages or put a lien on your house, it seems very reasonable to me that they could go after that as well.
Anyone over here?
Good evening. Personally, I am a service-connected disabled veteran. I do not have TRICARE because I did not retire from the military. I only did 14 years. But with that said, as far as I'm concerned, I support the Affordable Care Act. I have some questions directly for you. Since you did not mention it, what does Americans for Prosperity propose for health care reform? Number one. Number two, what does Americans for Prosperity propose to lower health care costs? Number three, was not the Affordable Care Act, aka Obamacare, wasn't it not originally a conservative concept, i.e. Romney Care? And number four, when you made mention of the issues of privacy, as it stands right now, in the event of an individual having a child support case against them, that's processed through city, state, and federal. So all three of those government entities share the information.
So I'll just quickly say that since you addressed specifically Americans for Prosperity, we primarily advocate for market-based solutions to healthcare issues, but we also believe that the things that we've been talking about here tonight that Josh and Christine had discussed from Foundations for Government Accountability are primarily policies that we would agree and advocate for. And I'll let you guys take the questions.
All right, I guess I'll take the last two then there about wasn't the idea behind Obamacare a conservative concept? Well, you know, I think that there's, this is an interesting debate that we've seen largely discussed in D.C. There was a concept that came from the Heritage Foundation about an exchange. But exchanges look really different. It's like saying all cars are the same. I think anybody that knows anything about cars would simply say that's not true. There are very different ways that a car can be constructed, the quality of it, the choice, can you customize it, is it appropriate for you? It's a little bit like Henry Ford saying you can have any model of a car as long as it's Model T and it's black. That's kind of what's happened under the federal law is regardless of whether you have a state-based exchange or a federal exchange, the federal government retains the power to deny any sort of change that you want. So I wouldn't say that that's necessarily a conservative concept, that the federal government holds the power over the structure of the website that displays all of your insurance options. A conservative concept would look like what Utah tried pre-Obamacare, which was we're going to set up a very tailored exchange in which we have a very light hand and it's targeted at small business and part-time workers in particular because Utah has some of the highest per capita, I think it's the highest or one of the highest, per capita part-time worker populations. I think that is a little bit more of a market-oriented conservative idea than what we've seen under the federal law. And I'll just end by saying this. From a research perspective, we were kind of curious about this question too. So we dug into the numbers and said, does it matter if you have a state-based exchange or a federal exchange? Do premiums differ? Does the ability of the state to set it up and mean anything different in premiums? Guess what? They're almost exactly the same priced products on average for 30-year-olds, which is what we looked at. To me, that reflects and says, just because you have a state entity running something, if the federal government ultimately retains the ability to rubber stamp or deny the structure, that is no longer a conservative concept and market-oriented. Because you have a bureaucrat in Washington saying, I know what's best for Kansas, Massachusetts, New York, Vermont. That's a real challenge. I don't trust myself to make that decision. I don't think we would trust most of the folks in D.C. given how they've rolled out this law so far.
I just wanted to follow up on the cost issue, which I think is a major issue. I mean, it seems like the costs keep going up, so more people get insurance. Then the costs keep going up, more people get insurance. And I don't think anybody will disagree that it should cost $50,000 to get a knee surgery, or $100,000. No one will disagree with that. And I mean, clearly there's a disconnect with the buyer and the seller, because the insurance company gets involved. My question is, why don't we look at countries like Australia and Singapore that have a single-payer system, like a two-tier system, a single payer for everyone as a catastrophic option. And then below that, they have health savings accounts, and the buyers and the sellers, the doctors, actually work together to figure out pricing. Because, especially in Alaska, the pricing here is out of control. You can send somebody to the lower 48 after you pay for their hotel and their airline ticket and still have as much as it costs here. So I don't know why so many people are scared of a single-payer tiered system where everybody's not going to go bankrupt if they get cancer, but at the same time they have tax-deferred health savings accounts, which will allow people to figure out what things cost. That's my question.
I'm going to let Josh, the insurance expert, deal with this, but I've heard that concept is why not have universal coverage with a catastrophic policy, and that might make the most sense. I worry about crony capitalism in that scenario, and we see that play out with Obamacare. My definition of basic is not your definition of basic. And we've seen this play out with the law. The government mandates that you buy a car. Maybe you want a Honda, but the government says you have to buy a BMW. And so I worry about kind of mission creep with that kind of universal coverage but with catastrophic care. I worry about the line of lobbyists that would show up to the government's door because the government is now defining what a catastrophic policy is. We saw this with the essential health benefits. You might have seen this lady who has stage 4 cancer, and she had an op-ed in the Wall Street Journal talk about her plan is going away because it didn't have, among other things, pediatric dentistry or maternity coverage. And she said, I'm a 46-year-old woman with stage 4 cancer. Why do I need maternity coverage or pediatric dentistry? I think that's what's going to happen under that kind of scenario. But I'll let Josh give you his opinion.
I have friends who live in Singapore, and they think it works great.
Yeah, no, and I think Singapore largely does work well. The political situation is a little bit different than the United States, but I think from a philosophical standpoint, we would be sympathetic to catastrophic coverage. I mean, it is horrible that 50 million people in our country are uninsured and worried about medical care. And why costs have continued to go up, the analogy I think of is if you go to a restaurant with a group of 6, and you're going to split the bill, you order the more expensive meal, don't you? Or maybe the waiter or waitress recommends. That's kind of what we do now. You go to the hospital and they recommend the more expensive procedure because you're not paying, the insurance company is paying, even though you paid the premium to pay for it. So I think we have some of these disincentives certainly there. I mean, I think health savings accounts could be revolutionary in this, and we have seen some steady success with their implementation statewide. And it allows for that value seeking. For those, sorry, I should step back. For those that may not be familiar with health savings accounts, look like a debit card. You can put money on it, tax advantage money on it. Your employer can put tax advantage money on it. It's triple tax advantage, typically, depending on, in most states, but in some of the more highly taxed states and the lower 48. But as a result, what the research shows on this is that immediately people ask the cost question in a good way. I mean, I have a personal anecdote because we often experience healthcare in a very personal way. My wife needed her blood drawn. I told the doc, he said, go downstairs and get it drawn. And I said, we have an HSA. How much does it cost? He said, I have no idea. So I called the billing office. I said, how much would it cost? $450 to draw her blood in the hospital. I said, that's ridiculous. I've got to be able to find it cheaper. So I called Quest Diagnostic, which is a kind of fast food type medical facility that does a lot of blood work. $50. That's the sort of, I think that starting to address some of those cost issues. I mean, that's a pretty big difference from my perspective. And that was because I had that financial incentive. So we've seen adoption. I think we're up to 4.5 million people in the country using HSAs. I think we just need to engage in our healthcare in a very different way. The last kind of analogy I'll say is when you buy a new car, you research. You talk to your friends, you go online, you read consumer reports, however you go about doing that process. We're in essence buying, especially here in Alaska, we're buying a very nice car every year in the form of your health insurance. But yet we don't want to spend any time thinking about it. Every single year. So we've got to change the mindset of all of us to say each year we need to shop around, we need to pick a plan that's appropriate for me or my family, and then try to go out and do those values.
So we have, we're going to actually do this as our final question right over here. The clock's at 6:40, and I know that there's some other media questions that we didn't get as well. So, final audience.
I'm Ilona Farr. I'm a family practice doc, and I actually read this stupid bill twice because I read both the House and Senate version. I immediately, when it passed in November, I immediately opted out of Medicare, Medicaid, TRICARE, and decided I wanted to do a charity care practice instead. And so that's what I've done with my Medicare, Medicaid, charity, uninsured patients. And it's worked really well. But the problem is this bill puts the government totally in charge of our health care. The IPAP board, which isn't enacted until 2019, is going to tell me what services I can provide and what they will pay me. We've got the PCORI board. We've got all these new audits because in the bill they have the RAC audits, which are commission-paid audits for Medicaid and Medicare. So there's a lot of audits. There is so much administrative stuff in this bill. I mean, they funded 16,000 IRS agents, but only 500 healthcare workers. What kind of healthcare bill is that? So I really am in favor of health savings accounts. I am in favor of making insurance tax deductible because even with these exchanges, they still don't have portability. It cannot be moved from state to state. Medicaid is an absolute trap. Once we start it in the bill, the way that it was originally worded, we cannot get out. And it does not allow upward mobility of people at all. They're stuck. And these exchanges stick them too, because if they get a bonus or if I bonus my employees, and they're in the exchange, they will have to repay back all of their subsidies. So this whole thing is a trap. It's a government takeover of health care, and that's why I'm so concerned about this whole thing. But what I'm really concerned about also is the number of physicians that we're seeing that are actually leaving private practice or about to leave private practice. And I saw some statistics that said that up to 78, it used to be that 33% of physicians were employed by large corporations and the government. Now it's up to 78%. And my concern is that we're not going to have the individual care. We're not going to have the flexibility to work with patients on an basis anymore. Like, for instance, in my practice, 50% of my breast cancer patients were diagnosed under the age of 50%. So I want to do mammograms lower, at a lower age than what the government is saying. But yet in the future, I may be fined by actually performing what I think is in the best interest of the patients. So, you know, what are you guys doing at a national level, or what's being done at a national level to actually help with this physician shortage? Because if you don't have physicians taking care of patients, you're not going to have, nobody's going to have a good quality of care. We've already got an aging physician population. People are coming out with $300,000 loans now. So, I mean, we've got so many other things that we have to address here besides just, you know, this Medicaid expansion. What else is being done?
A lot of points there, and this is maybe tenuous water, given that there are a handful of doctors in the room, although in there anyways. I do think that our medical system is going to have to change the way that we interact with it, and I think physician assistants and nurse practitioners is probably the next line of this, and whether it's kind of in the policy scope of practice, what we allow certain people to do. Do we need to say, see an MD to get a flu shot? Probably not. You've seen a lot of other states, retail clinics or convenient care clinics have played a larger role in people's, for very basic sorts of care that they need. They can go to CVS or Walgreens or whatever, or Rite Aid or Walmart or wherever to get some basic care. I think we're going to have to really think through how we interact with the healthcare system. And the things that we don't need to go to a hospital for, to see an MD for, then we need to move those to a lower cost setting. And that leads, I think, MDs to do what they're trained for, which is to make sure that they're working with the most complicated patients and helping coordinate the care for their panel. And so that means working with nurse practitioners and physician assistants to make sure that they're catching people that have problems. But that is a big cultural change in a lot of places in this country. And I think that we're going to have to just continue to have that conversation. State legislators certainly play a role in that, but I think we as consumers play a role as well.
We actually have independent nurse practitioners up here. Pharmacists can give flu shots and vaccines. We use health aides in the villages that are supervised by physicians. So Alaska is actually pretty far ahead compared to other states with regard to that. But you also have to be careful because you have to have someone that has the experience to be able to pick things up. And if you don't have the continuity of care like you do in primary care, you're going to miss a lot of stuff.
That's right, and I do think that doctors play a very important role in this conversation. This is not about pushing the envelope just to push it and blow up the healthcare system. I think everybody taking a swallow, being a little bit humble, and saying, how do we reimagine the healthcare system in any way that we can? And I think Alaska's trying to do it largely out of necessity, is my impression. So I think that hopefully Alaska continues to think through those delivery system models and tries to lead the country in that way. And I hope that we can be part of that conversation going forward, because it certainly is a necessary one. Well, thank you all so much for coming. And I invite everybody out to the lobby with some refreshments.